y'all can see that first slide, correct? Not if you can see the intro. Okay, perfect.
All right. So again, this is session 14. We do have a couple of announcements. Yes, they are recorded. Remember that. There is free CME. Make sure you fill out the form. I'm not sure I'm that good at it. Just make sure you hit submit when you're done. Remember that we would love it if you had your videos on. That just makes it a lot more fun for Dr. Heather, since she's doing most of the talking today. Next slide.
This means attendance. So if there's other people in your room, please chat it in.
All right. Upcoming echo sessions again tomorrow. I'm doing a talk. We had somebody that had to reschedule, and they'll be coming back at a later date. So I'm going to be doing a talk on everything buprenorphine. Some interesting little tidbits about buprenorphine and kind of a little bit of a review. So then we have some other great ones. The following week is actually Ryan Carroll from HIDA, and that's going to be a great talk as well. So lots of fun things coming. Again, if you need technical assistance, please let us know, and we're happy to help you. Our numbers are there. You can also get a hold of our nurse, Erin Voss. She's always happy to help you out and direct you to the right place. And again.
Okay, so we now have our website up, the Center for Opioid Resources and Education. This was actually part of the Wednesday Echo grant. It has so much information there. You can actually click on this link. It's got stuff to attend all the echoes. It's got stuff if you need paperwork and all of that. It's going to continue to update as Kurt and I update things. Okay, I'll do this. This is my complicated side. So I just wanted to give a lot of different options as far as people submitting cases. You know, ECHO model is case-based learning. I did throw another case throughout. We'd really like, she's taking care of that. We'd really like you to submit cases. You can go to the MAFP website. It was in your announcement email. Otherwise, if you go to the website I just showed you, the core website, here's the actual link, or you can click here on that first page, click on View All Echo under Attend. Then if you go to this Echo session, which is the Tuesdays, you can click the More button, and then you'll see right here, fill out, save, and email the form. Very similar for the Wednesday ones, except you'd click on the Wednesday Echo session, not the Tuesday one. So,
yeah, to be honest, if somebody during the thing has a case that they just want to just shoot at us during the at the end of a session, we don't mind that as well. So,
and then coming up next Friday, so a week, like in 10 days, I think it is, up in Grand Forks in person, there is a free, no cost boot camp that we are going to be doing, kind of the whole, how do you do this? What, you know, let's get this going. Let's get MAT, MOUD in your clinic, all the stuff. So you can meet us in person.
That's weird.
That's how you register. Or just email us if you want to register and you didn't click on that fast enough.
And remember, we have about 106 or 7 different topics now in the Addiction Connection podcast. Today was released
Xylazine.
Oh, Xylazine, which is a horse sedative, which is in about 10% of the patients who die of overdose in Minnesota, roughly 8 to 10%, something in that range.
It's like a super fascinating topic that when we taped it, we just had to like squeeze it in as fast as possible.
Yeah, so something that'd be pretty interesting.
And then if you have questions or you want us to do a podcast on anything specifically, I am tangenting right now, please email us at the Addiction Connection podcast. We have had someone from Maine, and now we have a new best friend. I have a new best friend from like the backwoods, Australia. Oh, yeah, anyway.
All right, the objectives for today, kind of reviewing the pregnancy complications with OUD, some of the best practices, and then of course, just a little bit of talking about the basics of NOWS, or neonatal opioid withdrawal syndrome. And now from St. Cloud, Minnesota, Dr. Heather Bell.
Where's my applause?
I introduced you.
Just kidding. Okay, so fatal opioid overdoses. This is just the women data. This only goes through 2019. It's darn near impossible to get new data. I mean, that's actually not that bad, but you can just see the rise, just like opioid overdose deaths in general. This is how percentage of opioid use disorder when people come into the hospital for delivery per 1,000 deliveries. You know, you can see the cases of moms who have a known history of opioid use disorder. This is very old data. I dug and I dug and I called on friends, and this is as much as we got during COVID, messed with everything. So we can only imagine how much higher that is. So why is this a topic we are talking about? And obviously maternal complications. So patients who are using substances, moms who are using substances, a lot of infectious risk, whether it's because of IV drug use or it's because of some of the behaviors that happen to get substances. Many women don't pay for drugs on their own. They use something else. And so a lot of risk of infection, injury, overdose, and death pretty clearly. And then just as far as when we're coming to the pregnancy itself, preterm labor, placental abruption, all sorts of things, which then of course impact the baby. Fetal growth restriction is a huge one, especially obviously if we're having stillbirth, preterm birth, and dating can be wrong if you're not having adequate nutrition and all of that. And it just all plays in there. When babies are born prematurely, all sorts of things, neurological issues, NICU stays, infections that can cross the placentas if moms are being exposed to that. And then the thing we're going to talk about today towards the end is the withdrawal syndrome, neonatal abstinence syndrome, neonatal withdrawal syndrome, and we'll kind of discuss a little bit of what the heck the difference is. Before I go to that, I want to explain the VHS tapes behind us. It is National VHS Video Player Day.
Thank
how
goodness.
You say it?
Yes.
Anyway, so I did throw a case throughout this. So if Mark is on, apologies, Mark. I added this 20 minutes ago. He is not on. Okay, so case, 20-year-old female. She presents to the clinic with her significant other, and she basically says, I think I'm pregnant. She does rightfully acknowledge heroin use, methamphetamine use, and nicotine use. Very just interesting demeanor. So this was my patient, and this was several years ago. On exam, general, has very thin face. She's very pale. She is very red. She has red hair. So it's like it's pallor because she's not adequately nutrition, all of that, or is it just her natural? But she just looks pale and thin in her face and extremities. Her pupils are very pinpoint. She has kind of icky dentition, not horrible, but just you can tell she hasn't brushed her teeth in a while. Heart is actually regular. There's no murmurs, any of that. Her lungs are clear. She has just recently started injecting substances. So you can see that in her skin. There's no other areas, but in the antecubital fossa, nothing obviously infected on that exam. Abdomen, I lay her down and she is very clearly pregnant. Her belly measures 26 centimeters. So that means we're thinking already somewhere into the second trimester. Easy to find fetal heart tones about 150. When I talked to her about, are you feeling the baby move? She's not quite sure. It is her first pregnancy. So doesn't really know. So we get an ultrasound that day. They date her around 28 weeks. And so that's right at that cusp of third trimester, second trimester. So this dating is like plus or minus 2 to 3 weeks. So we kind of have to keep that in mind. Is she really only 25 weeks? Is she really 32 weeks or 31 weeks? We don't really know. As obviously not at any prenatal care. Urine drug screen is positive for everything she said it would be positive for, except she did forget to tell me about the marijuana, but very infrequent use of that. These are poll questions, but not really poll questions. It's more for, if you want to chat it in or if you want to just think about it in your head. What is the most important reason? So you have a patient like the one I just discussed, and you're like, well, great, what do I do? If you're most of the people in the world who have a pregnant person show up, you panic. If you're in an ER, you panic. If you're a most person who does OB and you see all these substances, you panic. But what should you do in this situation, especially, why should you use medications for opioid use disorder? So really the number one reason is to improve prenatal care compliance. Obviously it's the infections, it's all the things I said at the very beginning. It's to prevent preterm labor and all the things, but the really number one reason is to improve prenatal care. So if these people are coming in, if these moms are coming in, they will, for their pregnancy, for their MAT, the babies and moms both do better. So other actual benefits as well, besides just that, it prevents withdrawal symptoms, cravings. Withdrawal can increase the risk of miscarriage, especially in the first trimester, but it can definitely create abruption issues, dehydration issues, malnutrition, blah, 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 later in pregnancy as well. Being on MOUD decreases the injection drug use, so therefore infections, other risky behaviors, and then, like I mentioned, the adherence to prenatal care. So different ways we can look at treatment of opioid use disorders in general in pregnancy. So MAT, MOUD, the new terminology, you'll see both used in here. It's still easy to say MOUT or MAT for me. MOUT.
Yeah, easy for you to say.
I know, it's MOUD is hard to say, MAT is easy. Anyway, so it is recommended for moms to have MAT. And when I say moms, I'm trying to, it's easy to say moms. Technically, we should say pregnant persons, because a mom is a person who has children, and this might not be a person who chooses to parent. So the pregnant person. Methadone or buprenorphine. Alternative would be a lot of counseling, buprenorphine, naloxone, so Suboxone, Naltrexone. We're going to talk about all these. And then non-MAT options, which is very not recommended, is detoxification, so helping them get off of their substances, and then abstinence-based. If you look at ACOG, American College of OBGYNs, and then SAMHSA, basically everything I just said, just with fancy quotes. So methadone, when we're looking at methadone, we all remember it's a full agonist. It's been around the longest. Advantages in pregnancy, it's established. It's been around the longest, 1974. So we kind of have monitored many pregnancies with moms on methadone. We know it's safe in breastfeeding. We know it decreases cravings. It has a long duration of action, a high treatment retention, because methadone clinics, of course, they're going in every day. It does have the known positive impact of reducing complications. Disadvantages, it takes a while to get to that stable dose. One thing that wasn't on the advantages is you don't have to start withdrawal to start it. You can take a person who's recently used and you can just start your methadone. They don't have to go through withdrawal, which is good, of course, like I mentioned a minute ago with the withdrawal potential issues for baby and pregnancy. But it can take a while to get to the appropriate dose of methadone, because you can't just jump to a dose. There is no perfect conversion. It takes a while to get there. There is significant overdose risk. This is somebody who is early to recovery, clearly while they're pregnant, pregnancy, all the hormonal things, social stressors. I mean, all the stressors that happened early in recovery on top of all the stressors happening early in pregnancy, which is a nightmare time, I think, for a lot of people, especially if you combine the two. So the overdose risk is there, because you can still use opioids on top of methadone and get, euphoria. Daily treatment at the OTP. Another disadvantage of that is the opioid treatment program is always not the same place that they get their obstetrical care. So now they're going to two different clinics, one of them every day, the OB care, depending on what the OB decides. So it's just extra things. It has now shown that babies whose moms are on methadone, or the pregnant person on methadone, do have almost guaranteed some type of withdrawal syndrome that does last a little longer and can be more significant and baby needs more treatment. So if a mom is on methadone, again, this has been the one that's been around the longest, what should you do if a mom is on methadone? Do you decrease the dose as low as possible to try to mitigate some of those withdrawal? Do you increase the dose? Do you consider completely tapering them off the methadone so baby doesn't have any withdrawal? Or should you consider changing that all the way to buprenorphine? So if you want to chat in the number, because I didn't make real poll questions, so it's not anonymous, or you just want to think about it in your head, that's cool too.
I'll just think about it in my head.
You better know the answer to this question. So the actual answer is you're probably going to need to increase the dose. So almost typically very counterintuitive. If you're thinking about it just quickly. And often you need to split that dose. So methadone is typically dosed once daily. It's not uncommon in pregnancy to need to dose it twice a day, even if they've been stable on methadone for a really long time. And that is, you have increased metabolism when you're pregnant, especially with that placenta. There's increased volume of distribution. Your blood supply or the blood volume goes up 1.5 times being pregnant. And so things break down faster and they have more space to be. So often they do need to go up on their dose. So it's really just listening to those symptoms. And then often you will have to split it into twice daily dosing just because they are starting to metabolize it and they can't make it that full 24 hours. So if we're talking about buprenorphine, so Subutex, the straight buprenorphine product, again, partial agonist, antagonist at the mu receptor, all the different variations. The advantages are it does have at this point very good established pregnancy and breastfeeding safety, lower overdose risk, of course, because it is blocking basically that receptor. And so using something on top of it, you're not going to have that overdose risk or that euphoria. Many fewer drug interactions than methadone. You can do it in an office space. So if you are somebody who does buprenorphine and pregnancy care, such as what I did, I can do them both in one visit. They have found over time, and this data just continues to add up, is that babies will have much shorter withdrawal, if they even have any, and it's much less severe. So they might not need medications at all. One disadvantage, though, disadvantage, blocks opioid effects. There are long-acting formulations, although in pregnancy typically will stick with the daily sublingual.
It's interesting because it doesn't say on there. One of the other things is it doesn't seem to be dose related. And you should talk about that.
I will get to that with the case.
Okay,
if that's okay. And
perfect.
I'm glad you said that though, because that's my new friend from Australia. Disadvantage, I say it like we've been besties forever. She sends these really long emails at 4:30 in the morning because she's in Australia. But anyway, limited data. We don't know what happens to babies. And this is obviously buprenorphine's not been around the longest. So what happens in 10 years after mom was on buprenorphine during pregnancy? Really, there's still not fabulous data on what happens to the babies whose moms are on methadone either. It's just, since it's newer, this is always going to be something said. You do need to have mom be in some withdrawal though before starting buprenorphine when they are pregnant, because we don't want to precipitate that withdrawal. And so this is a little bit more of a finesse thing, whereas methadone, you can start it right away. Not as successful if they are using multiple substances. And that's just because, the methadone clinics, you have that daily visit to get dosed. Buprenorphine clinics, we don't typically do that. I'll get to the case in a second. So, and that would be the same with the lower treatment, lower structure. We'll explain that. Buprenorphine, though, is the same as, and maybe I'll talk about the dose now. The buprenorphine is the same as the methadone. Typically, the dose is going to also need to go up. And, my new friend from Australia, she's been on buprenorphine for 9 years. She's now pregnant. Part of her wants to just get off of it, but she said she started to taper her dose and started to have all of her cravings were coming back, as what would happen even if you weren't pregnant. And then, one of her OB said, well, let's just get you to the lowest dose because then your baby won't have as much withdrawal. Actually, that's not true. A mom could be on 2 milligrams of buprenorphine or 24 milligrams, and the babies could have the same amount of withdrawal. They could have no withdrawal. And so the dose is not correlated with the amount of withdrawal for baby. And so that's reassuring to a lot of patients. Now, diversion is real, which is real for every patient who's on buprenorphine or Suboxone, is that if they have it, they can share it. When it's just plain buprenorphine versus Subutex or versus Suboxone, which has the naloxone in it, you can inject it, you can snort it, you can abuse it. That's why the naloxone is in the Suboxone, is so you can't do that. And so, especially in early recovery, it's how much do you have them, who's around them, are they going to be at higher risk, of diverting? But buprenorphine, the standalone Subutex, is the new considered gold standard for pregnancy treatment. So methadone or buprenorphine kind of get the same. So now if you want to talk about Suboxone, so you throw the naloxone in there. When you are taking Suboxone, whether you're pregnant or not, that naloxone really doesn't get absorbed. So it's only there so you can not inject it. So if I were to melt my Subutex, inject it, I could get euphoric. If I melt my Suboxone, I inject it, I'm going to get sick because that naloxone is there. That is the only purpose. So if it is taken correctly, that naloxone doesn't get absorbed. So therefore, it should not negatively impact baby. But there's just not a lot of studies, which is why they say plain buprenorphine is the recommended. So those would be the advantages, disadvantages, and just switch from one to the other without, having to make any big changes. It's the buprenorphine dose. But what should you do as far as what does SAMHSA say? If someone's stable on the Suboxone or the combo product, that's a conversation. And I've had multiple patients who were on Suboxone. I've had one want to change the Subutex. Everybody else just like, don't mess with what I'm on. Like, just leave it alone. And so it's a bigger conversation when they're new to recovery and pregnancy. So back to the case. So, the significant other is also using IV substances, the same substances she is using. She is a high school graduate. She was actually a 3-sport athlete, straight A student in high school. Not going to go into that whole social story. They currently live with his mom, who is a known person with the substance use disorder, not known to me, not known to Kurt. It's just like one of those things in a small town. You think you know, or you kind of know, or you hear rumors. It's pretty well known that she also is probably selling substances or dealing drugs in the community. And so that's her living environment. Her biggest supporter all growing up with was her dad. She called herself a daddy's girl now that he literally doesn't talk to her. So that's creating additional stress. Her mom tries, but kind of feels lost because, she's using and doesn't know what to do. The mom doesn't know what to do. And then patient currently does not work. So here we are in a clinic in tiny little town, Minnesota. What do I do? Methadone? Do I recommend buprenorphine? Do I recommend the combo product? Or is abstinence? Like, what do we do here? So kind of think in your head, just quick thoughts. How about this side by side?
Nice.
I didn't have time to write pros and cons under each one, but I'll just kind of say, this is kind of summarizing what I just said on the other slides and putting it in context with her. So methadone, yep, it's been around the longest. Can she get it? Well, from where she lives to the closest methadone clinic is a good 45 minutes one way. Not working. She doesn't drive. She can, but she doesn't at the moment. She's already 28 weeks pregnant. The benefit would she wouldn't need a withdrawal first, but she's already 28 weeks pregnant. So my goal, again, back to the number one reason you want to treat this in pregnancy is prenatal care compliance. So am I going to make her go somewhere 45 minutes away one way and come see me, or is it better to do in the same place? So then we have this thought is, do we just do the plain Subutex, the buprenorphine? Technically it is the number one it is recommended, but again, there's this IV risk. There's this diversion. She's in a home where there are substances at this moment. The fear, of course, is I need to get her into somewhat of a withdrawal first. And right now, remember, she has pinpoint pupil, so she is not in withdrawal right now. Or do I choose Suboxone, the combo product? Again, we don't know what naloxone does, but there's that minimal diversion risk in terms of abusing. So she's not going to be injecting this, but can still be diverted, but other people won't love it. And again, still need to go through that withdrawal first. I probably forgot things on here, but again, I did this half a hot minute ago. So kind of think about those things. If you want to write in the chat what you would do, really there is no wrong answer of those three options. I will tell you, of course, what I did in a minute. But if you wanted to chat in just your thoughts, that'd be cool too. So then I purposely skipped this before I got into the case details. Naltrexone, so Vivitrol, that's the once monthly injection, the complete opioid antagonist. Advantages, They say it reduces cravings, although anecdotally, I don't see this in my patients. Reduces overdose because it's that complete antagonist. It completely blocks that receptor. Obviously can't misuse it or divert it because you're getting it injected once a month. It is office-based, so they're having to come in. Disadvantages, limited safety data in the pregnant population. And then it's the same kind of thing with anybody is what happens if they have legit pain, they have a car accident or they have a C-section, or what do you do about the pain? And at delivery, especially a first-time mom, you're going to have pain. And what do you do about it? And there's really no known breastfeeding safety. Why'd you look at me?
No.
Were you going to ask me if there's pain at delivery?
Yeah, I was going to say, really? Pain? Okay.
Labor hurts. Okay, so, if you look at all the expert panels, the ACOG, SAMHSA, there's no agreement. If the mom is already on it, what do? You probably shouldn't start it. If they're already on it, it's kind of the risk benefit. This is where I'd be calling in my perinatology addiction friends, and just kind of plan for it. They're in recovery. Do you really want to mess with it? And go from there. If they're pregnant and you're debating starting them, probably not a good choice, especially because you have to get them completely off of all their opioids before you can give that first dose. So now we're really looking at a lot of risk. So then we can discuss medically assisted withdrawal. So helping mom taper off of the substances and maintaining abstinence for the remainder of pregnancy. The recommendation in pregnancy, though, is you need to start something. It's typically a buprenorphine product or methadone, and then you slowly taper that down. You just don't want that whole withdrawal thing. Very close medical supervision for this because you don't want to create that withdrawal. If they're at home and they're not in a stable environment and you're trying to taper them off, the risk of relapse is just astronomical. There's not great long-term outcomes. Like obviously you'd say, well, if the mom's completely off all substances at time of delivery, clearly the baby is not going to be having any withdrawal from that substance. But what does that mean for mom and baby though, in reality? So should you have the goal be medically assisted withdrawal? So getting every mom to abstinence? No, you really shouldn't. That's literally the opposite. So advantages, again, it will have minimized neonatal withdrawal, decreases neonatal care costs because if these babies aren't having withdrawal, they're not technically going to be having increased, stays in hospitals. Disadvantages, you can see up to 90% of relapse, which overdose, especially if they were in recovery for even a couple months, they lose some of their tolerance and then they relapse. It's scarier. Very low compliance rates. Relapse is a completely relapsed. This compliance rate is people on and off and on and off and on and off. It's just not recommended. I'm just going to end with there. So expert panel, not recommended. MAT is the best option. Only, recommended if there's these other options and MAT is unavailable. It's just not an acceptable answer anymore.
I think that one of the things to always remember is when we talk to patients about stopping MAT when they're not pregnant, they have an 86% chance of relapse in that first 5 years if they stop before 5 years. So I don't know that we should expect the pregnant patients to have a different outcome. The outcome's not going to be great. So, yeah.
And I love that my Australia friend, she said, I've been on this for 9 years. My goal when I started at MAT was never to be on this even a year. And now here I am 9 years later, I could just get off of it. My life is stable, blah, blah, blah. But even she's like the anxiety and the withdrawal symptoms she was having. And she just was like, I cannot even imagine relapsing while pregnant. And to me, that was so telling, just 9 years in. This is the really fancy thing that they do at the University of Minnesota, because you must have a fancy flow chart. So anyway, you can look at that. So what should you do though? I mean, ultimately, end of the day, everything we do in medicine really should be shared decision-making. I say it like that because of residency, but it really is all about the patient. You know, ultimately at the end of the day, it's their body, it's their baby, but they need to know the risks and benefits. So if you have these conversations, you can kind of see that patients actually can get to a point that they do make very well-informed decisions. It's really understanding what their goal is and what they're afraid of, and having them understand, like, here is your risks and your benefits, and have them kind of point that out to you. You know, yeah, I'm living in a home where everybody's using. Okay, how do you think that's going to actually impact you? So back to the case, we did choose a Suboxone induction. Flat out, we discussed it, but really, you know, the best option for her was going to be the combo product, especially in the situation she was in. High stress, 24 weeks pregnant, or 28 weeks pregnant again. She came in saying, I think I'm pregnant. So this is a huge shock. No, you're like almost done being pregnant already. And then with the substances in the home and all of that. So my couple fears for her was, if I let her leave completely because she's not in withdrawal, am I going to see her back tomorrow? It's that same kind of thing. And so she hung out for a while. They went and got lunch. She came back. She was in very mild withdrawal. Now, this is heroin days, not fentanyl days. And we started her very low, and she did well. And so I saw her a couple of times that first week, and then the next week a couple times. And I actually saw her weekly until the end of pregnancy. So we had great compliance with her pregnancy care for that third trimester. And we did get level 2 ultrasounds. We got her up to the high dose. She was using IV opioids. She's pregnant. Let's get her on the high dose. And this was I only called her in a week of meds at a time. So you got to kind of treat both things simultaneously. And any 28-weeker who shows up pregnant at 28 weeks, you're going to see frequently. This just helped me. So when you're looking at the end, you know, we mentioned this, the prenatal care, you have to have conversations with the OB provider, and the MAT provider need to have this communication open. It helps if you're the same person. You need to think about these things ahead of time. You know, 28 weeks is kind of when I would start having the conversation of, okay, this is what we can expect for your pain management. Because patients who have an opioid use disorder are going to be afraid to ask you about their pain after delivery, because they don't want you to think they're asking for pain meds. And so bringing it up. Here's our plan for pain management after delivery. And yes, here is what neonatal opioid withdrawal syndrome is. And here's how we're going to approach your opioid withdrawal syndrome, your babies, and we'll get to that. But having these conversations ahead of time so they know what to expect and they don't feel blindsided. And then let's see what we can do as far as getting you parent support groups, getting you connected with social services, talking about lactation, all of the things that you would want to do for a first-time mom or anytime mom, as well as things you'd want to do in early recovery or in recovery in general. So then what do you do though if this mom is currently using substances? Now, what would you do at this moment in this day and age in Minnesota, I should say? Do you have to report all substances of abuse to the state? Do you have to report no substances of abuse, alcohol only, marijuana only, opioids, illicit only, stimulants only, or combinations, or none of the above, which I guess would be the same as B?
Trick question, maybe.
Trick question. It's tricky. Just kind of think about that. So at current day Minnesota, you really don't have to report anything. Now, this is a definite change from like a year ago even. Prior to now, and prior to 2022, you had to report everything except marijuana and alcohol, which still to me is mind-blowing. Now you don't have to report any of them. That being said, it's still recommended to get, you know, social services involved, but you don't have to report. So what did I do? Despite this being 3 years ago, and she's clearly using substances that are reportable, I did not report her. And the reason I did not report her is this is a gray zone. You could use your way around it for a minute, is she was clearly not using the substance is in my office when I saw her at that first visit. And then I induced her that same day. So I didn't have any delay where I knew she was still using or had that potential. And this was a high risk patient.
Buprenorphine induction?
Buprenorphine induction.
Sound like you did a
Oh, no, not a baby induction. I'm sorry. Yeah, it's so complicated. When I started her on Suboxone, this is, again, a high-risk person. If I'm like, okay, I have no choice but to legally report you at this moment, even before I start you on your Suboxone, and here you are with your significant other who's also under the influence, and then his mom's in the car also under the influence, I would likely have never seen this person ever again until she showed up at the hospital and just like delivered a baby. So I did induce her that same day. Every single urine drug screen I got from that point forward had nothing in it, all negative. That's not even the right terminology. They were all appropriate. They all had just buprenorphine in them. But by week 2, I said, let's start connecting you with things that we can do to help you. So I got social services involved. So did I do a formal report? No, but I still did social services. I made aware of this patient. So she got connected with WIC. She got insurance. We did we got connected with all the support services that reporting her would have done, but in a more patient-centered, family-centered way. And so this is where the legal challenges come in, the mandatory reporting and why that was a bad thing. It's really important for every person who is pregnant to be screened for use disorders. And universal screening with the urine drug screen does not count. It has to be like an actual assessment. The 4 Ps, which is not in here for some reason, the 4 Ps, like the letter P model, is the easiest screening model in pregnancy to use. As far as like a person comes in and you want to screen them for any kind of substance use. Reasons why women would not come in to get prenatal care. And so why people, like, even if they knew they were pregnant, they would just delay and delay and delay because they were fearing they were going to lose their babies. And that's why we took this law away. Staff training, lack of support, lack of information. Here's kind of where the answer's involved. So then labor and delivery, like I mentioned, it's always important to have these conversations up front. But what does labor and delivery look like? If they've never had a baby or they've never had a baby while in recovery, it might look different. Early epidural, we do recommend, because if they're on something like Suboxone, which is kind of, it's going to help with some pain control, they end up with a C-section, how's their anxiety going to be? Sometimes the pain of labor can be triggering to a patient who has an opioid use disorder because, they maybe liked pain meds in the past. And so we do recommend the earlier epidural, not early, but think about ways you can handle that C-section. Tap blocks. So, and anesthesia can do super fabulous things these days. They can numb the nerves before the mom gets out of the C-section, which can help minimize pain meds. Maybe a PCA where you're actually going to have them get fentanyl or something else besides taking the oral pain meds. It's really important to know what their drug of choice was to try to avoid that. If they liked Vicodin, maybe we do go to Oxy. You got to kind of be aware of what their drug of choice was. But ultimately, most vaginal deliveries do not need stronger pain meds than Tylenol, ibuprofen. It's more planning for that C-section. So what happened? She showed up at labor and delivery I think she was like a couple days after her due date. Baby had always done amazingly, so we didn't have to induce her early with pregnancy inducing. Urine drug screen was appropriate for just buprenorphine. She ended up needing a C-section. So I was like, oh, good Lord. I'll be honest, this was my first C-section with a Suboxone mom. All previous half a dozen of them had been vaginal. So it was like, great, what are we going to do? The anesthesia that I had on call that day was amazing. We did tap blocks, so we numbed her from the OR. We gave her 1 dose of fentanyl IV after delivery. She got a dose of Toradol after delivery, so fancy ibuprofen. We continued her same dose of Suboxone the entire way through. So she never missed 1 dose from prior to the hospital until she went home, same dose the whole way. And she had Tylenol and ibuprofen. That is all she needed for pain after a C-section. Again, the buprenorphine is going to offer some pain relief. Breastfeeding, minimal transfer of the meds to baby. Only time patients shouldn't breastfeed: hepatitis C if they have bleeding nipples or they have ongoing illicit use, or HIV. It doesn't really help. The biggest reason to breastfeed, if you're in any type of a MAT program or anybody, is that bonding with the mom. It helps minimize any type of withdrawal as well. Never forget they can get pregnant right away, and most pregnancies in patients who are using substances or even in recovery are unplanned. And so it's making sure even in the hospital you talk about, how are you going to not get pregnant again if that's what they're not wanting to do. And then, so what is neonatal abstinence? We're going to kind of flip quickly to the baby. It's any type of withdrawal that the baby shows signs of. So any type of nervous twitches or cries or any type of symptoms the baby shows because of anything the mom was on. This can happen to a lot of things. Most medications, it can happen with moms on insulin, for goodness sakes, tobacco, alcohol, all substances. It's not just opioids. So then they came up with NOUD, which is the opioid specific withdrawal. Big range of who develops it. More common in moms who are using illicit substances, so ones who are not in an MAT program. More common in moms who are on methadone than buprenorphine. And the biggest take home from this entire talk is, please, babies are not born addicted. They cannot go out and buy drugs and do inappropriate things to get them. They're born dependent. And it's not a baby that has NAS. It's a baby. It's a baby who has NAS or a baby who has neonatal opioid withdrawal syndrome. You don't name the baby NAS baby. That's just not patient-centered. So the timeline, and this is timeline depending on the drug, can change. Now this is the MAT timeline, methadone or buprenorphine. If it's IV heroin or fentanyl, it's going to be much sooner. About 4 to 7 days. It's about 72 hours is the average, the peak of opioid withdrawal syndromes in babies if they're on a buprenorphine product. So what do? Babies observed in the hospital for 5 days. So rather than going home with mom on day 2 or 3, you keep the baby admitted for 4 to 5 days. You discharge the mom, but the mom stays in the same room with the baby. So you can do that. Average length of hospital stay historically with the baby having opioid withdrawal syndrome was 16 to 20 days. That has changed. This is the old-fashioned way of monitoring babies who have withdrawal. I'm not going to go through it all. Most people know it. If you do know it, you can forget it. Just kidding. So basically, the scoring would start within 2 hours of birth. You have to do it every 3 to 4 hours. You'd have to wake the baby up, and you'd have to do all these things, and things like baby crying gets points. So you'd treat baby for opioid withdrawal depending on the score. Now we have this new model, the eat, sleep, console. So basically you look at the things that baby needs to do to transition to being outside of, the mom. Can the baby eat? Can the baby sleep? Can the baby be consoled? Anything outside of that is like any baby, even if they don't have withdrawal of anything, can still have. So if the baby can do these 3 things, you continue to monitor the baby. If they can't do 1, 2, or whatever of these things, you try to increase nursing, you try to increase skin-to-skin contact. You really want these babies whose moms are on opioids to be swaddled. You want a quiet, darker environment. I loved COVID for this because you'd say don't have visitors, and then COVID just made it easier to not have visitors. And if they don't improve, then you have to consider treating with morphine. This is just fancy to show that babies who had the eat, sleep, console model needed far less morphine, if anything, compared to babies who didn't, or who had the Finnegan scoring. So back to our patient. Mom did choose to breastfeed. She was officially discharged on day 3 because she had a C-section, stayed in the same room though. Baby, we discharged on day 5. Eat, sleep, console model, baby roomed in completely except for, the middle of the night testing they have to do. Baby kept swaddled. No medications were needed. Baby did not have significant enough, any type of withdrawal to need any assistance. Baby went home with mom. Because her urine drug screen at presentation was completely appropriate with buprenorphine, They tried to take the baby. Child Protection did, knowing mom had been using up to 28 weeks. I fought it, and they said, you have to wait until I have a meconium screen back. And the meconium screen came back a week later with only the buprenorphine in her system, or in the baby system. So mom got to keep this baby and have that togetherness. We won't talk about what's happened since. But long-term, like what happens? We don't really know. What we can say is that babies whose moms were on methadone, who were on buprenorphine, had no more problems than the babies who didn't. More babies are going to be with mom long-term, or with the parenting person long-term if mom was treated. And then obviously there's not that increased risk of infection and all of those things. So, and then Susan just popped on. I'm sorry, Susan, I need to point you out. Susan runs this amazing, amazing thing with MDH, where it's all about making recommendations to all size hospitals, big, small, rural, not rural, on QI things to do just this, to screen for moms with use disorders, treating moms, monitoring babies in patient-centered ways. So
that's it.
That's it.
Questions from anyone?
Questions, comments?
You can chat them in, or you can unmute. That'd be fine. Or not.
And nobody has their video on right now. Not one person.
All right. Well, I think you might be done.
Oh, perfect. Slides from today, and Kendra, I did change them by putting that case in. I don't know if that's important, if people want the case or not. If you don't want the case, there you go. And then to do your survey to get your CME, there you can click on that. Otherwise, you should be getting it in the email. Recording, you can click on that. Otherwise, that core website I showed you at the beginning in the announcements, you can get the recordings and the slides from that as well. CME, though, is only for the live session.
Yep, and just remember tomorrow.
Thank you, Susan. I'm sorry. Susan put the link for the perinatal, Minnesota perinatal on there. So it really talks about all the things that this amazing group is doing to go through this. And thank you, Sarah.
Yeah. And tomorrow, the talk on buprenorphine, it's going to be a quick review, but some different information on using with benzos, the interesting studies on the ceiling effects, some of the things we normally don't talk about. So it should be kind of interesting.
Yes. And to join that, you can email. I'll put Katie's email in there. Otherwise, you can go to that core website and register to join that Echo from there.
My haircut looks great.
I know. Not yours. Mine.
Oh, what? I thought it was my haircut. Jeez.
Yours doesn't look great. Just kidding.
All right, everybody. Well, thank you so much for coming. We'll see you in a couple of weeks or at the Echo tomorrow. Everybody have a good week.